From the JAMA Network, this is JAMA Cardiology Author Interviews. Conversations with authors exploring the latest clinical research, reviews, and opinion featured in JAMA Cardiology.
Hello, everyone. My name is Jim Udelson. I'm Chief of Cardiology at Tufts Medical Center in Boston and a Professor of Medicine and Radiology at Tufts University School of Medicine here in Boston. And I'm delighted to be here today for a JAMA Cardiology podcast with my two guests, Professor Marianna Fontana from London and Dr. Sarah Cuddy, also from Boston. Let me introduce you to them. Professor Marianna Fontana is the director of the University College of London Cardiac MR Unit at the Royal Free Hospital. She's a professor of cardiology and an honorary consultant cardiologist at the National Amyloidosis Centre in London, one of the top such centers in the world for the study of amyloidosis. It's a part of the Division of Medicine at University College in London, where she's the deputy head of the center and a deputy clinical lead. Welcome, Marianna.
Thank you very much for the very kind introduction. It's a pleasure for me to be here today to discuss this paper.
And we also have with us Dr. Sarah Cuddy. Sarah is an assistant professor of medicine at Harvard Medical School and a cardiovascular medicine specialist at the Brigham and Women's Hospital here in Boston, with a special interest in amyloidosis and cardiovascular imaging. Dr. Cuddy did her internal medicine and cardiology training through the Royal College of Physicians in Ireland, and then came to Brigham and Women's for a cardiovascular imaging fellowship, also doing a fellowship in cardiac amyloidosis. Welcome, Sarah.
Yeah, thank you very much for the kind introduction and the invitation to partake in this podcast today.
Great. Thank you both for being with us today. Marianna, JAMA Cardiology published your paper entitled Tracking Treatment Response in Cardiac AL Amyloid with Native T1 Mapping. Before we get into details of the paper, one of the reasons the editorial group was so interested was our impression that general cardiologists over the past few years have seen a lot of information about TTR cardiac amyloid, a lot of publications, but less so about AL amyloid. Can you just give us a brief primer on the difference between the two entities in terms of pathophysiology, diagnosis, and treatment?
Thank you very much for the question. It's really an important question to be aware of the type and also of the different pathophysiology and treatment strategies. So in ATTR amyloidosis, which is now felt to be the most common one, there is a protein, the transthyretin, which is normally produced by the liver, but then in these patients misfolds and deposits as amyloid into the different organ and tissues. And is a progressive and fatal disease with a prognosis of 2.5 to 30 years in patients with cardiac involvement. Instead, in systemic AL amyloidosis, there is a plasma cell dyscrasia at the level of the bone marrow, which is able to produce free light chains, then misfolds and deposits in all different organ and tissues. So one of the key differences of AL versus ATTR amyloidosis is the multisystemic involvement in AL amyloidosis, where the deposition of amyloid can affect almost any organ. And also the other key difference is the prognosis. If we leave patients with cardiac AL amyloidosis untreated, the prognosis is less than 6 months. And even 1 month in a delay in the start of treatment, which is for this patient is chemotherapy, is associated with worse prognosis. So cardiac AL amyloidosis is really a medical emergency. And as cardiologists, we need to be fully aware of it. And if there is any suspicion, we need really to proceed fast to confirm the diagnosis and start the chemotherapy.
Thank you so much. Very important distinction. Sarah, as further background, again, before we start talking about the details of the study, which involves tracking a treatment response with native T1 mapping by cardiac MR, can you just give us a brief run-through of the cardiac MR metrics that are involved here, especially contrast-based extracellular volume measurements and native T1 mapping? What does all this mean?
So cardiac MRI gives us a lot of functional and structural data similar to echo, like wall thickness, LV mass, which are helpful in kind of some measures of disease burden where we say there's thickening of the myocardium wall due to infiltration of the amyloidosis. But the real advantage of cardiac MRI is tissue characterization. So we can use gadolinium contrast in this method, and we see diffuse gadolinium throughout the myocardium when there is clinically significant amyloid infiltration. So this is a very kind of typical, nearly pathognomonic image that we see on late gadolinium enhancement imaging. And often, if the protocol involves an inversion time scout, we can see that the gadolinium kinetics are very abnormal. Now, I wouldn't expect a general cardiologist to kind of know the ins and outs of that, but it is something that the technicians will identify when they're doing the scan and say to us that they're finding it hard to null the myocardium. And that all kind of relates to the T1 characteristics. So, what we can do from MRI is get the T1 characteristics of different tissues. So they all differ pre-contrast, and then we give the gadolinium, and that shortens the T1. So the T1 characteristics change pre and post contrast. And we can harness that to get something called the extracellular volume. So we can estimate the extracellular volume using T1 characteristics pre and post contrast in MRI. And that's a proxy measurement of the amyloid burden within the heart because the amyloid deposits within the extracellular space. So as more and more amyloid deposit, that extracellular space expands. And that's why we see so much gadolinium within the myocardium in AL amyloidosis once we give that contrast. But we actually know just using the T1 maps pre-contrast that these T1 values are very elevated in amyloidosis, and much more so than we see in other pathologies, especially because it happens in such a diffuse process. So sometimes we'll see focally elevated, what we call native T1, that means pre-contrast T1 values in a myocardial infarction. But it's when we see a really diffusely elevated T1 throughout the myocardium that is generally nearly pathognomonic for amyloidosis. One key component is we cannot differentiate the type of amyloid just based on these MRI characteristics. So we cannot differentiate if it's light chain AL amyloidosis or ATTR amyloidosis. Both of them have pretty similar characteristics on MRI.
Great. And just one quick follow-up. So the advantage, I assume, of the native T1 is that you don't need contrast. And that is helpful, I assume, in people with advanced kidney disease and may shorten the acquisition time.
Exactly. Though gadolinium contrast agents we're finding are safer than we thought before in advanced kidney disease, but there is some hesitation, especially in an AKI, to use them. And as well, the native T1 values provides a composite signal that's influenced by both intracellular and extracellular components. So it's kind of giving us additional information potentially over the calculation of the ECV.
That's great. Thanks. Okay. Now that we have all that as background, Marianna, can you walk us through the objectives of your study and the methodology?
Yes, so this is a single center cohort study that evaluated patients that were diagnosed with cardiac AL amyloidosis between 2016 and 2020, who underwent a cardiac MRI at diagnosis and repeated at 6, 12, and 24 months. And of course, after diagnosis, this patient started treatment, which was chemotherapy. And the aim of the study was really to assess whether the native T1 mapping could measure the cardiac treatment response and also to assess the association between the changes in native T1 mapping and prognosis.
Thanks so much. So what were the key findings of the study?
So the study comprised 221 patients with systemic AL amyloidosis, and the key findings were that in patients that the native T1 over follow-up behaved differently in different patients. So there was a group where the native T1 reduced, and the reduction in native T1 was associated with also reduction in maximum wall thickness, improvement in longitudinal strain, and reduction in both T2 and ECV. Once an increase in native T1 then was associated with an increase in NT-proBNP, reduced left ventricular ejection fraction, and increase in both myocardial T2 and ECV. But most importantly, the reduction in native T1 was only seen in patients with a very good hematologic response, whilst an increase in native T1 was only seen in patients with a poor hematological response. So there was a clear correlation between the changes in native T1 and the hematological response. But most importantly, we found that a change in the native T1 at 6 months was independently associated with prognosis after adjusting for all known predictors. So the key findings is really that native T1 was giving us additional information on top of what we currently measure to assess the treatment response, which is the reduction in free light chains, i.e. the amyloid production. And so why an ACT1 was so powerful? Because it was telling us something about what was happening to the myocardial substrate in response to different degree of reduction in amyloid production. And the best response was in the patients where we could not only decrease the amyloid production, but on top of that, the patients could respond in terms of cardiac amyloid regression. And this is really the key of why these cardiac parameters are so important, because give key information on the myocardial response to the chemotherapy and to the amyloid production.
Can you envision, would a next step be, let's say that the native T1, you have a certain hematologic response, but the native T1 information is telling you that the myocardial response has been suboptimal. Is there a treatment implication at the moment for that?
Absolutely. And we are actually choose about the first line chemotherapy regimen is very straightforward in these patients. As soon as they've got systemic amyloidosis with cardiac involvement, this is a clear indication for the treatment. But it's way more complex to decide about what to do with second line chemotherapy regimen or for how long we should continue the treatment. And really, at the National Amyloidosis Center, where the decision about what to do in terms of second line or how long should be the chemotherapy treatment is really a multidisciplinary decisions where cardiologists, hematologists, nephrologists, they all come together to discuss the patients. We are really giving more and more importance on the cardiac MRI findings in terms of amyloid regression. I'll give you a very kind of easy example. In a patients with a 90% reduction in the free light chains, which is really at the cusp between very good partial response and partial response, we should have a very different behavior if we see on one patient cardiac amyloid regression or on the other one cardiac amyloid progression. Because what we found is that similar patient with a similar reduction in amyloid production can have a very different response in terms of what happens with the cardiac amyloid substrate. And of course, patients who regresses with a certain degree of production will have a much better prognosis than the patient who progresses with that degree of reduction. And that we take into account with other many factors like renal response, for example, and global function response to actually decide if we need to get a deeper response in some patients as opposed as, or actually in these patients, we are happy because from an organ perspective, the patient is doing extremely well.
I think it's really key with helping make that decision between first and second line chemotherapy and when to introduce second line agents. But also, I think what I touched on my editorial is so far in amyloidosis, both in ATTR and in AL amyloidosis, the approved therapies target the protein that misfolds to produce the amyloid. But now we're at the point where we have phase 1, 2, and 3 studies investigating antibodies that attack the amyloid fibrils that are already deposited themselves. So that's where the information garnered from this study is really key to understand what's the normal response of the myocardium to standard of care therapy. And then when we're employing these antibodies therapies that are directed specifically at the amyloid deposited, what's going to be a significant change and who are the patients that would benefit most from these antibodies versus who just require standard therapy alone.
I completely agree with Sarah, if I can add something, because what we clearly see is that in 40% of the patients, just giving chemotherapy then will be associated with an ongoing regression. But actually, 60% of the patients will never regress. And as Sarah pointed out, it will be key to establish in which patients chemotherapy will be enough and in which patients is absolutely key to target the amyloid deposits. So this imaging modality will be actually crucial to have drug development in this sense and actually being able to measure and track the amyloid deposits with antibody treatment that target existing deposits.
Marianna, Sarah made the point earlier about cardiac MR not really being able to distinguish the interstitial deposition, whether it's TTR or AL amyloid. Could the findings that you report here be applicable in tracking a treatment response with regard to the cardiac interstitium in TTR amyloid? Because I don't think of serial pyrophosphate scans, for instance, as having been shown to be useful in that regard.
Yeah, so first I completely agree with Sarah that cardiac MRI shouldn't be used to distinguish between the types. But in terms of the second question, Are we likely to be able to apply the ECV and native T1 to also track changes in TTR? I think we will be able to do exactly the same. So there is a paper where we showed in a very small group of patients that when we treat patients with gene silencers, and the paper was in patients treated with patisiran, we could see in a proportion of the patients a reduction in ECV. And I'm absolutely certain that once we have larger studies, we will be able to show the same also with native T1. So I think that all we are showing in AL, we will be able to replicate in patients with TTR. And it's just really a matter of time. It's just because only very recently we started to have available treatment for patients with TTR that can be used in clinical practice.
Sarah, one issue that we talk about in our manuscript meetings at JAMA Cardiology when thinking about important papers like this is the generalizability of the results. Here, in this paper from Marianna, we have data from one of the top amyloid centers in the world with world-class cardiac imaging experts. In your editorial, you discussed specific issues around the generalizability of the imaging results, and in particular, the native T1 mapping data. Can you tell us more about your thinking on that and how generalizable are these data?
Yeah, so native T1 mapping is a sequence that's available from most MRI vendors. So you can say to Siemens, Philips, GE, I want the T1 mapping package, and they'll install it on your MRI scanner. But the values are really scanner dependent. So they vary hugely if you're using a 1.5T scanner versus a 3T scanner. And then there is even variability just from scanner to scanner. So it's harder to set definitive thresholds to say, oh, a native T1 value greater than 1300 means this, and a change means that, because there is some difference between scanners. So that's where kind of the generalizability is limited more so with native T1. Extracellular volume kind of gets around a lot of these limitations, and we are able to kind of have more generalizable thresholds and cutoffs with extracellular volume. For example, a lot of studies done from Marianna's group, the National Amyloidosis Centre, and smaller studies that we've done here and have been done in other centres show that around a cutoff of 40% really indicates a clinically significant burden of amyloid within the extracellular space. We definitely see patients whose extracellular volume is lower than this, but it doesn't seem to kind of reflect with that many clinical symptoms of heart failure. Whereas once they go above that 40%, we really see them start to manifest signs and symptoms of the disease. So that's where the ECV is a little bit easier to generalize across multiple centers and multiple scanners.
That's great, thanks. And my final question, Marianna, just briefly, you touched on this a moment ago, but just give us a glimpse into the future here. Can we expect more amyloid removal to be possible with upcoming therapies?
Thank you very much for the question. I think this is a very topical question at the moment. We recently published, I think it's less than 2 weeks ago, the case of 3 patients with ATTR amyloidosis that naturally developed antibodies anti-TTR and completely clear the amyloid. And this was associated with, of course, reduction in ECV, but also remodeling of the structure and function back to normal. For us, that was a very, very important finding because it was the first proof of concept that amyloid is a completely reversible condition and that really treatment targeting the deposits is the way to go, is where we need to concentrate all our efforts. If you think about patients with AL amyloidosis, once they've got in advanced stage, there is absolutely almost nothing that we can do. We start chemotherapy, but the mortality is extremely high in the first 6 months. And the only way to target the very high early mortality is really to remove the amyloid deposits first and then go with chemotherapy. So if I think about the future of treatment in both AL and TTR amyloidosis, I see really a combination of strategies that reduce the amyloid production and then remove the existing deposits as really the key treatment approach that hopefully we will have in the next 5 to 10 years in patients with cardiac amyloidosis.
That's great. I want to thank you both so much for being with us and sharing your insights. The progress in the field of both of the major types of cardiac amyloid has been really breathtaking over the past 10 years, and it sounds like it's accelerating quickly. thanks in part to the work that both of you are doing. So thanks so much for being with us.
Yeah, it was a pleasure. Thank you very much.
Thank you very much. It has been a pleasure.
My name's Jim Udelson. I've been speaking with Marianna Fontana from London and Sarah Cuddy from Boston about the paper in JAMA Cardiology, now published, looking at the use of native T1 mapping by CMR in AL cardiac amyloidosis and the accompanying editorial. You can find a link to the paper in this episode's description. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com or search for JAMA Network wherever you get your podcasts. This episode was produced by Daniel Morrow at the JAMA Network, and thanks very much for listening.